But this one I'm holding closer to them, and this one they really can't see. There's a couple of things with people with dementias, and especially with Alzheimer's, is that they begin to lose the ability to see anything other than bright colors. So when we go to see patients with dementia, we want to make sure we're wearing some pop of red, some pop of neon green, some pop of orange, because that's what they see. So if I'm offering them something to wear for the day, I want to make sure that I'm offering them basically in the same color scheme so that there's not a lot of confusion. And let's say this is the one back here that I'm holding that they always wear, and I'm trying to get them out of that. So I'm going to offer this one, right, closer to them and right there. And this one's going to have that nice color. This one will be about the same color, but it'll be behind it. And that way they'll choose what I know is best for them. Not what I want them to wear, because oftentimes it may actually be hot outside, but they still want to wear a sweater, don't they? Because they're cold. They're cold.
Yeah.
So I may want them to wear a little sweater rather than that great big furry heavy one that they're wearing. So I have to figure out how to do that, okay? So that we're still doing what they'd like, but what's best for them, for that situation. All right, so moderate impairment of basic activities of daily living. This is where you really come in to help out. All right, mid-stage. In mid-stage, anybody heard of sundowning?
Yes.
Okay, it is, yeah. It's a phenomena with especially Alzheimer's, but it happens in lots of dementias. It's the late stages of the day, and it's caused, they believe, by the long shadows. So it gets worse in the fall because all of a sudden we go back to daylight savings times, right? And we fall backwards in our time. So now it's going to be darker sooner, and that causes this sundowning. The sundowning is normally 3, 4 o'clock in the afternoon, they start getting agitated. They're like, they're restless, they don't know what to do, they don't know where to go, and you'll start to ask them something, they'll be like, no, I don't want that. Okay? You're like, whoa. Well, that's the sundowner. We have a patient that we're with right now, and normally she's cute and just does her thing, and even though she has dementia, she wears purple all the time, and she's about this big, and she has that little shuffling gait, and everything's fine. But about 4 weeks ago, 5 weeks ago, we started seeing, don't do that. I don't want to do that. She's not wearing her purple, or her purple's kind of out of her shirt. Her hair is not combed anymore. She used to wear this little bow. The bow's not there. She has sundowners. We're seeing it. Now, what I want to remind you is that that's normal sundowners, if there is such a thing as normal sundowners. What can happen is, if patients with dementia get their days and nights mixed up, and they're up all night long, they're going to have sundowners all day. So you have got, routine is so important with a patient with dementia. You've really got to try and keep them on a routine so that hopefully they go to bed at the same time every night and hopefully at least get some sleep. That's why we tell our employees to make sure that you don't let people sleep during the day. I mean, maybe they take a little cat nap, of 30 minutes, but you want to be doing activities. You want to be getting up every hour and just walking around the living room if that's all you're doing. You want to be playing puzzles. You want to be doing Old Maid. You want to be doing all kinds of just activities that you can. We do jumbo playing cards. These great big playing cards really help because you can see the numbers really great, right? And you don't have to play like Rummy the real way. You just play it, okay? Old Maid cards come big like this, and it's a matching, and they love that, okay? I get books like at the dollar store, and like this one. This is Liz Taylor, so this is someone that they would know, and so there's these beautiful colors through here, and they can look through them, and we look through it, and we talk about it. And it may not be about Liz. Like I might go, oh, look, she's got a lasso. Did you ever ride horses, or do you like horses? It just gives me a jumping off point. Where can I talk to them about it? So I keep my little bag with me for all kinds of things in here. I have a game, and this is a game that I got at a yard sale. And you turn it on, and it does a pattern. And so they can do the pattern. Let me ask you a question. Does it matter really if they get the pattern right?
No.
No. It matters that they're punching and I'm doing some eye-hand coordination, and I'm doing it. And on here, it's so funny. When you get it right, the machine goes, hurrah! You know, so what I do is even if they don't get it right, if there's a little buzzer on there, and they got it wrong, then it's a buzzer. And I'll go, oh, you got it right. And they'll go, I did? Yeah, we did. Let's do it again. So what's more important is that they're enjoying and doing the things and you're keeping them busy. We can take activity bags like this and just have a bag with balloons in it, or, you know, have, like this has a big magnifying glass in it. And it's really cool to just look at stuff and see how big things are, okay? You know, anything like this. I keep this in here. This is an old money, right, drawer. And it's like a child's drawer with money in it. So we'll count out money, or we'll count out pennies and quarters and change, you know, real money. We'll do all those things. An activities bag, bean bags, right? We can toss bean bags. And this is actually a rice bag that I just made, you know, and we toss rice bags. We'll blow up the balloons and we'll hit balloons back and forth to each other. And you saw my activity bag had pictures on it. So there's like, you know, George Washington, and there's Shirley Temple and the Statue of Liberty. Things that they could recognize and be able to put together. It's so important, so important. We have one lady who used to be an avid sewer, and her bed is actually in that room with the sewing machine. It's so important that we do something that's sewing. She's mid, coming right into end stage, but there's always something that we can do. We can get a needle point. You know, that they have those great big needles, and it kind of has a dull end. We could get a needle point that she could just have the motion of going up and down. What difference does it make if she doesn't do it right? It's the motion of being able to do that and tapping into that old memory, okay? So it's really important. So we have that sundowning, that late day confusion, and you want to make sure that anything you can do during the day to keep them active will help decrease the amount of sundowning at night, okay? All right, last stage, end stage. Look at this, 1 to 3 years, shortest stage. They zip over here. Why do you think that end stage is the shortest stage?
They just want to be done with it.
Yeah, they just want to be done with it.
Deteriorating.
The body's deteriorating. Yes, all of those things come together. And in fact, like my dad, he just said, I'm done. I'm done. This is too much. And they really can will themselves. We've seen it where we have one patient who, he was on hospice. They only gave him a few weeks to live. And his daughter came over and said to him, his youngest daughter came over and said, Daddy, I'm pregnant. You're going to be a grandfather. Well, here we are, 2 years later. He's still alive. They took him off hospice, and he has begun to try to walk again. The brain is such an amazing, amazing thing. Okay, I talked to his wife over the weekend, and they have a swimming pool, and he's actually out in the swimming pool with a therapist. So it's amazing to me what the brain can do, and because he wanted to live to see, and you can imagine what that grandbaby is to him. She is just the apple of her granddaddy's eye, I'll tell you. So it's so important in this late stage. And you know what the Alzheimer's Association says? If you've seen one person with Alzheimer's, so I'll say to you, if you've seen one person with dementia, you've seen one person with dementia. Because that means that every single person is different. We could have thought that gentleman, and he was, everybody thought that. He's on hospice, he's at the end, but the will to live came over him, and he is still going strong, okay? But it is the shortest stage, and usually this is where we see death coming very rapidly. You'll see that increased risk of skin infection and breakdown, and a major increased risk for falls. Usually, even a fall will be what takes them out. A fall or an infection of some type. They fall once, and they just don't seem to be able to come back from it. Loss of bowel and bladder control. We still might toilet them every 2 hours. In fact, we encourage our aides, toilet, toilet, toilet. Even if they're wearing Depends, you toilet every 2 hours, right? Because the bladder can be trained. I was on a spinal cord injury for a long time when I was a nurse on the floor. And we were actually able to train bladders to go off at a certain time, even though that person had no feeling from the waist down. So a bladder and a bowel can be trained. But they got to wear Depends now. because they have no feeling, they have no control over it. Yeah? And difficulty swallowing. You as the healthcare professional have to start looking at how do I chop up the food little? Do I take the edges off the bread? One of the things about swallowing is that as we increase in age, our saliva decreases. And they've actually done autopsies and found third-degree burns on the esophagus from where most elderly seniors take pills and they'll take a swig. Just a little swig of drink, right? You don't drink and drink and drink. Well, we're talking about your pills have to go from here to here. That's a long way to go with just a swig, which is a little sip of water, isn't it? So those pills have actually gotten stuck. So that's so important that you're able to make sure you add gravies to things. You don't give them a lot of just dry bread. You've got to do things to make sure they do not aspirate, which means that fluid goes down in the lung, because that can cause pneumonia and death. All right, working with a dementia client, make sure you build a relationship of trust. Approach from the front. Identify yourself, okay? Do they need your entire first and last name and your credentials? No, they do not. They just need, hi, I'm Dawn. That's all they need, okay? Smile, smile, smile. One of the things I talk about, those eyes. Your eyes have to be so expressive. Like I'll overdo it when I'm with a client. And remember we talked about depth perception?
Yeah.
So if they can't see from here down, how close am I going to have to be to them for them to really see my face? I'm going to have to be within 3 feet of them.
Yeah.
So right now masks are so important for that, right? Because then I can at least get closer to my patient. Call your client by their name. Remember the very beginning picture where that little girl was in the mirror?
Yeah.
What if her name, because I used to call my brother Bubby. His real name was Sonny. But when we were growing up, everybody called him Bubby. My mom called him Bubby, and everybody called him Bubby, all right? What if he's that little boy, like that little girl in the picture, he has dementia. If I call him Sonny, is he going to know who that is? No. He needs to know who Bubby is. So when we call him Mr. Smith, he's like, who's that, right? You have to know what name they recognize, okay? Speak slowly and softly. I made a mistake one time of thinking that the people couldn't hear me, and every time I talked, they went like this, whoa, whoa. And after about the third time, I was like, oh my goodness, Dawn. They're not deaf, okay? So they can still hear you. If they have a hearing impairment, of course, that's different. But just because they have dementia doesn't mean they can't hear. And use touch. Speak slowly and softly and use touch. And decrease the number of words and give them time to hear you, to think about the answer and respond. Build a relationship of trust by using those short sentences. Maintain your eye contact. Be patient. Care about their feelings. Care about their feelings. Limit the choices. Like I was showing you the red jacket and the red, limit the choices and break tasks into simple steps. Watch that peanut butter and jelly sandwich. How many steps are we going to make? Brushing the teeth. How many steps is it going to take? Watch out. Break it down. Risk factors we've talked about is age, family history, genetics, if you've had a previous brain injury, okay, depression, medication side effects, thyroid problems. Oftentimes people in their late 60s and 70s go undiagnosed and they have hypothyroidism. So you really got to look at that. Vitamin deficiencies. Yep. All right, here are your drugs. Here are your current drugs. Aricept, Razodone, Namenda, Exelon, and Namzaric. The ones that we find that are used, and not all of them can work on everybody. Oftentimes, certain drugs don't work with people. So Aricept is the number one drug, the number one that we see. Namenda, the number 3 one there that you see, that is actually the number 2 drug that we see used most often. Aricept and Namenda. And then number 5, you see it just came around in 2014, so it's only a few years old. Namzaric, I've even found just a doctor within the last year who didn't even know Namzaric existed. Namzaric is Aricept and Namenda put together. And it's been very effective for mid-stage, which they call moderate also, so mid-stage, all right? FDA approved, the brain, the neurons connect. With Alzheimer's, it's synapses. I talk about it's like going to a yard sale and finding necklaces. They're all in an old box together and they're all twisted and torn and tangled, and you pull one out and all of a sudden two more get tangles in them. You have to look. That's the way the brain looks with Alzheimer's. It's got plaques and tangles. That's what it's called in Alzheimer's, okay? In that disease process. And it disrupts the thinking. Eventually it destroys the synapses, kills the neurons in the brain, which are the cells specific to the brain. It kills them. And that's what causes the breakdown in communication. All right. Look at this. This is so important, you guys. If you haven't heard a whole lot of what else I've said today, you really need to know this. Communication, the effects on care. 97% of behavior problems are the result of our communication problems. It's not the result of the patient. It's our problem. 97% of the behaviors of our client are caused by us because we didn't understand. We didn't keep them in their routine. We didn't know that they had to go to the bathroom. We didn't know an infection was coming. We didn't know that they weren't feeling well, and if we had just given them a little Tylenol, they would have felt better. We just can't know those things sometimes. And so 90% of their behavior problems are because we weren't able to do our jobs well enough and our communication techniques. Look at this next slide. This tells you about communication. Everything I have said for almost the last hour, only 7% of it was words. Would you have thought that? No, you would have thought that 90% of what I've done is words. Only 7% is words. What if I had just stood here, had never moved and talked like this and said that 7% of what you heard was words? That would have been awful for like an hour, right?
Yes.
Yes. So 55% is facial expression, tone, pitch, inflection, voice, speed, volume, and 38% is body language. So think about someone with dementia. Take away the 7%. The 55 and the 38 is what you need to use when you are communicating with someone with dementia. You need to use body language. That's why I talk with my arms. And you need to use all of this expression and pitch and volume. Okay? Do not correct or argue. Do not correct or argue. You will lose. All right? Make them feel okay. Remember, persons with dementia are unable to be rational. They cannot make judgment decisions. We have to go into their reality. If they tell you that they saw somebody in a bicycle riding through the living room, you better say, what color is that bicycle? All right, where'd they put the bicycle? All right? And you say, boy, it sure is getting busy in here then, isn't it? All right? You need to believe them because they don't have a reality. All right? That is their reality. They're living in that reality. The client cannot change. Remember, only we can. I'm going to end with a story about a client that I had. She was the third client that we ever admitted to Companion Extraordinaire. I was her care provider. And her name was Becky, and she was absolutely amazing. We cared for her for 10 years. She had beginning stages of dementia when we started caring for her. And she moved from her townhouse into a independent living, but it was in a community, knowing that eventually she would go to assisted living, then she would go to nursing home, and she would progress. None of us knew at the time, because this was at the beginning of Companion Extraordinaire, none of us knew that it would be a 10-year progression. We thought it would go quickly, but it was 10 years. So about 4 years in maybe, Becky and I went to lunch together. And the deal that we had worked out with her son, she only had one son, and he lived out of state. The deal we worked out was that we would go Dutch. And Dutch means 1 week I pay for lunch, 1 week Becky pays for lunch, okay? And she had a little credit card that he'd put like $100 on, so in case it got lost or anything, it wasn't a big deal. Well, we were at Bob Evans, which down in the Richmond area, Bob Evans is not too far from here. It still exists. And we went in and we sat down, and I was so thankful because Becky was at that stage where she just said what she thought. Okay, it just came up and came out. But Becky was a spiffy dresser. She had on these little, little blue pants and little heels about that big and little button up, the shirt button all the way up to here. And she had on those glasses, that had the pearls that come around the neck. So you can take them off. Oh, yeah. Take them off and set them down here. And she just was really always looked in the mirror and put her lipstick on like this. She was something, okay? And so we went into Bob Evans and they took us. I was so grateful. They took us all the way to the back corner of the booth. And I'm like, shoot, because she can just say what she wants. So the waitress comes over and the waitress has got her little tray and she comes up and asks what she wants. Well, Becky couldn't remember what she wanted. So I said, well, Becky, do you think we should get the same thing we got last week? Because that was a really good meal last week. And she said, oh, yeah, I think we should. I said, do you mind if I order for us? She said, no, you go right ahead. So I didn't make her feel bad, right? She just, so we ordered the chicken sandwiches and we're rolling on and the waitress leaves water for us and she goes off and about 2-3 minutes later, Becky's like, well, where'd they have to go to get that chicken? Now y'all know it's only been 2-3 minutes, okay? Only 2-3 minutes. Now, we don't have anybody around us except this one gentleman in a 2-seater booth right next to us. We're in a 4-seater booth right here, but he is right next to us. And I'm like, and I bring my voice down, because that's what we do to make everybody, just come in. So I said, Becky, I don't know, but I said, I'm sure they're working on it real hard. Look how busy they are. It's lunchtime. Becky, you remember when it was like when you were working and you went out to lunch? And I said, it's always busy. She said, I don't care how busy it is. They need to get that lunch and bring it on over here because I'm starving over here. I'm like, oh my gosh. Well, the waitress comes back over and she's got our drinks now because it was water, right? And she brings the drinks over and Becky is just fussing. Well, I had this little card that I created. I laminated and said, please excuse my friend. She has dementia. Okay, and that's all it said on it. And I took it and I put it on her tray, on the waitress's tray. The minute she saw it, her whole face changed. Yeah. She knew immediately, okay? This is what Becky said. Are you giving out one of your cards again? You are always soliciting business. I said, Becky, I'm always looking for good help. You know I am. So the waitress was wonderful. She takes the card. She smiles at me. She smiles at Becky. She apologizes for the long wait. Now, we may be 5 minutes in, okay? She apologizes for the long wait. She goes back to the kitchen. She lets everybody know that patient with dementia, we got to look at this, we got to look at the card that they gave me, blah, 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 blah. You can see her back there doing this. So they get the meal, they bring it out, we sit down, Becky and I have a very nice meal, we eat, everything's fine. This gentleman, he's gotten his meal, he's eating, we're just going on fine, everything is good. I am thinking that I am Nancy Nurse and I have just done the best job today, okay? I am just good. Well, all of a sudden, the little waitress brings the ticket. Well, she puts it down on the edge of the table, and it's my week to pay, okay? So Becky grabs the ticket. Well, I don't know what was wrong with me. I just lost my mind for a moment, and I said, oh, no, Becky, it's my turn to pay. Becky picked up that ticket, and she goes, it is not your turn to pay. It's my turn to pay. I'm paying this ticket. I was mortified. Because this man is still sitting next to us, and she's getting real loud, okay? And so I do what we learned in nursing school, which is what I call the social worky voice. And as a social worker, you bring your voice down, because statistics show that when you bring your voice down, everybody comes down with you. So I said, oh no, Becky, it's my turn to pay. Oh my gosh. If I told you once, I told you twice, it's my turn to pay, I'm paying this bill. Well, about that time, I got managers, I got the waitress, I got everybody coming over to me. I know I'm going to lose my nursing license. Okay, I just know that it is happening, all right? And I'm like, what am I going to do? What am I going to do? I can't think, I'm not thinking, right? The adrenaline is pumping, my heart is beating real fast. She is making a scene. She's standing up in the booth. She is just going like this. All of a sudden, the man in the booth next to us gets up, and I'm like, oh my gosh, okay? this is I've only been in business for a few years. I know I'm not going to be in business anymore. It's just awful. He comes over and he grabs the ticket out of her hand. He goes, oh, no, you're not. You're not paying today. I am. And he walks off. Okay?
Okay.
And this is Becky. She got the ticket. She goes like this. And so we're like this. All of a sudden, this is what Becky does. I knew I still had it.
Oh, Lord.
She did indeed. True story. She did indeed. It was amazing. The waitress, the manager, everything. That gentleman went on. He paid for the ticket. It was just incredible. We told that story over and over again. And when Becky passed, we told that story at her funeral. It was such an amazing moment. And even in her dementia, it was so incredible to see her move through that. I made a lot of mistakes that day. I try not to make those mistakes now, but you learn along the way. You have it in you to do a wonderful job with people who have dementia. And sometimes you're the only person who can afford them the life they deserve. I hope you learned something today. Take care.